This will move to our third presentation by Dr. Abdullah Alenezi. He will talk to us about clinical trials and bifurcation lesion. Dr. Abdullah is a well-known interventional cardiologist from Kuwait and currently is the head of cardiology of Chest Hospital.
Thank you for the kind introduction. It's my pleasure to be with you today discussing and having a quick journey with a fresh look in trials and evidence and bifurcation lesions. So why bifurcation PCI is important? Well, 20% of the lesions that you're going to face in your cath lab is going to be bifurcation. So you have to have the knowledge on how to deal with them. Bifurcation PCI is associated with more adverse events, and there are some controversy on the best approach to managing bifurcation. So if you are faced with a bifurcation lesion, what's the thinking process that you have in mind? Well, one option is to go with upfront two-stent strategy, which from the previous talks we are not liking so far. And the other option is to go with the provisional stenting. But truly, which one is best? Still controversial in my opinion. So if you look at this data from the Definition 2 trial and Nordic trial, the two-stent strategy, there's no question it's associated with more procedural time, more fluoroscopy, more contrast, and more equipment being used. So there are more complex procedures to go ahead with upfront two-stent strategy. Looking at meta-analysis from Dr. Nairi's and colleagues, comparing provisional strategy to upfront two-stent strategy, there was no difference in major events between the two approaches, no difference in target lesion revascularization, no difference in MI, and no difference in stent thrombosis using 7 randomized controlled trials. But interesting enough, when you look at all-cause mortality, provisional stenting seems to be superior with regards to all-cause mortality when it's compared to the upfront two-stent strategy. Another more recent meta-analysis by Dr. Ford and colleagues. This is just a slide summarizing the meta-analysis. They included 9 RCTs comparing provisional to two-stent strategy, included over 3,000 patients, and they found 30% relative risk reduction on mortality with provisional stenting. Again, replicating the finding of the previous meta-analysis. This is the finding from the Ford showing better mortality with provisional stenting in these 9 trials. And if you see on the right-hand side, the long-term mortality, when they took the trials that followed patients for 3+ years, the mortality benefit become amplified, suggesting that provisional is superior. Most of the trials that involved in this meta-analysis were presented mostly non-left main bifurcation. The EBC main trial was dedicated for a left main bifurcation, and it tests the same question, provisional versus two-stent strategy. So in this trial, they included over 400 patients. They compared upfront two-stent with provisional stenting. And what they found fewer MACE with the provisional stenting. However, this did not reach statistical significance. And probably didn't reach statistical significance because the sample size is small. It's only 400 patients. And maybe because the follow-up was short. It was only 1 year. But the good news for the interventional community that with both strategies in left main, be it provisional or upfront to stent, the event-free survival was very good, over 80%. This is the finding of the ABC main. Numerically, provisional is better, but as I said, it did not reach statistical significance. I think 2 important points that was touched on in the previous talks about that we can learn from the ABC main. First one, if you decide to do 1 stent in the left main, so provisional 1 stent technique, do we need to do kissing balloon inflation? Well, in the EBC trial, about 90% of the cases, they ended up with kissing balloon inflation. So in my opinion, if you want to get outcomes similar to the ones they got in EBC main with the provisional stenting, we should be doing final kissing balloon inflation. And this is one of the dilemmas that we have in the cath lab. The other important question, and this is a very, I'm going to reiterate this point back and forth, is that provisional stenting is a philosophy. It doesn't mean that you're going to use 1 stent. You can use 1 stent, and you can use another stent if you need to. So in the provisional arm, in 20% of the cases, they ended up putting 2 stents. So provisional doesn't mean it's 1 stent. It means you start with one stent and you add another stent if needed. So based on the totality of evidence, the 2018 Guidelines on Myocardial Revascularization gives a class 1 indication that if you are faced with a bifurcation lesion, you go provisional. Okay? And that's, I think, the message from the previous presentations. But is this really the end of the story? And I think that's the fresh look we're going to have on the evidence that we have. Is this the end of the story? And in my opinion, it's not. If you go back to the DK Crush 2 trial, which compared DK Crush upfront to stent to provisional, the MACE was actually better numerically with the DK Crush, barely reached statistical significance with the p-value 0.05. But if you look at target lesion revascularization, DK Crush was superior to provisional. Okay, we look at the DK Crush 5 trial, which was a dedicated left main bifurcation trial, and you find that DK Crush was superior to provisional in target lesion failure, target vessel MI, target lesion revascularization. So why are we getting these mixed messages? And I think one very important point, and that goes to one of the questions being asked, it's very important to know that in DK Crush 5 trial, by design, the operators in this trial, they were expected to have performed 300 PCI per year for 5 consecutive years, and they have to actually submit 5 exemplary cases of DK Crush. So they are not your usual operators. They are operators who are extremely experienced with DK Crush. So the point being, if you want to get results similar to the DK Crush 5 trial, you have to have a lot of experience with DK Crush. Okay? So we look at the Nordic Bifurcation 4 trial. There was no statistically significant difference between provisional and 2 stent, but there is trend toward better outcomes with 2 stents. And if we divided the patients who received first-generation drug-eluting stent, and I think that's one of the questions of the panelists earlier, and you look at the second generation, if you use the second generation, you ended up having better results with the upfront 2 stents. So if you're going to do bifurcation with upfront 2 stent strategy, having good skills and good stents will help you in getting better outcomes. So back to the question, why are we getting mixed signals from the evidence? We look at the definition score, which came from the Definition 1 trial, and this is a score that helps us look at lesions and decide whether the bifurcation lesion is simple or complex, because we don't think that all bifurcations are the same. We should not have the same approach for all bifurcations. Okay, so this is the definition score. And going forward, just in the interest of time, Definition 2 trial elected to use the definition score to find out complex bifurcation lesions and test the theory in specifically complex bifurcation lesions by definition score. If we randomize patients to 2 stent versus provisional, which one is better? And what we found that in this trial, the outcomes in the people who got the 2 stent were better when it comes to target lesion revascularization, target vessel MI, target lesion failure. All of them reached statistical significance that upfront 2 stent strategy is better. So if we go back to the guidelines, do we think that this guidelines should be changed? In my opinion, I think what should be happening when you are faced with a bifurcation, you should assess the complexity. If it seems to be simple by the definition, you should go with the provisional. If it seems to be complex, I think it's reasonable to consider upfront 2 stent strategy. And I think the evidence supports DK Crush more. So to summarize my talk, I think what I'm trying to deliver here, that one size does not fit all. Not all bifurcations are created equal. When you see a bifurcation, it should not be a knee reflex to decide you're going to do provisional. You have to actually look at the lesion and decide, is this simple? Is this complex? And if it's simple, you go ahead and do provisional. And in 20%, you should be expected to put 2 stents. Okay? If it seems to be complex, then you should decide to do upfront 2 stent strategy. Using definition score can be helpful, and you have to match the complexity of the strategy to the complexity of the bifurcation. And it seems that DK Crush has a better evidence, but as I said, if you want to do a DK Crush, you have to have extensive experience doing the procedure. Thank you for your attention.
Thank you very much, Dr. Abdullah. It's As usual, a nice overview of evidence. I'll just start by asking a question. Is it, in this, all of this data, there's two-stent strategy, a lot of steps, a lot of techniques, and operator experience. And as you already mentioned, that in the DK trial they need more than 300 DK crush procedure to be involved in the trial.
It's not 300 PCIs per year.
300 PCIs.
Yeah.
So can we apply this to any cath lab, any operator? Can anybody just graduated from his training today and from tomorrow he say two-stent strategy is better and I have to do this? Or we have to regulate this based on the experience?
I think this is a great question. The simple answer is no. You are not going to have the enough volume in every center to be able to do these complex procedures. But I think the first step is to assess the complexity. If it looks simple, then any cath lab can go ahead and do provisional. And if the provisional 20% you end up with another stent, you can use the TAP or Colot, go ahead. But if you see a lesion that's bifurcation, looks very complex, especially left main, where the stakes are high, I think referring to a higher volume center is very reasonable approach.
Great. Dr.
Thank you, Dr. Abdullah, for your presentation. Great, as usual. I want to ask you, you mentioned in your talk, of course, second generation is superior to first generation, and this is logic, of course. Any preferences regarding the type of stents, any data support, any special type for a special technique to support type over the other? Do any data is present to support this point?
To be honest, I'm not aware of any evidence support that one stent is better, but I think the newer generation allows you to have easier access to the side branch, and then you end up having high percentage of final kissing balloon inflation. I think that's the issue. The older generation, the first generation, the operators struggle to recross, they struggle to perform final kissing balloon inflation, and that's the issue that led to worse outcomes.
So it seems like second generation is same between all types of...
Well, now we have third generation, so...
Yeah, so thank you.
Dr. Haytham, you have a question?
I think this is just a comment I had, maybe just to follow up on the question here. I think with the second and third generation, what would really dictate your use is the size of the left main. If you're doing a left main bifurcation, knowing what stents on your shelf, a 3.5 or a 4, how big can you get them in the left main? And I think that is going to be very important. I think the second issue that Dr. Alenezi talked about, which is EBC main, which I think is really, really important. We've asked this question several times today. If you're doing a left main crossover into the LAD, do we need to open the struts to the circumflex? And if it's a true distal left main bifurcation, so true distal left main as an EBC main, even if you're using a single stent, you have to end with the kissing balloon inflation at the end. If it's not a true distal left main, if the circumflex is free of disease, okay, you do your crossover, you do your pot, and you don't have to do a final kissing at the end, okay? But if it's a true distal bifurcation left main as an EBC main, you had to do the final kissing then. So
I could not agree more. I have to admit that initially in my experience, I was not doing the final kissing inflation, specifically in left main, if it looks good. But after having a couple of patients come back with a stenosis of the ostium of the circ, my practice has changed, and it's supported by the ABC main.
Great. Last question, Dr. Hani.
I'm going to just make a very brief comment and make it succinct. We need to zoom out. Training in interventional cardiology in 3 years' time, fellowship will not make you a superhero to tackle all these complex lesions. Leadership of any organization should ensure that support to new career individuals is ongoing, and those people who are very senior and might not be even at that level should be also double scrubbing, and that is the role of the responsible officer to ensure that the organization is providing the best practice. Thank you.
Okay, thank you very much. Thank you very much, Dr. Abdullah Alenezi.